from the Heart of Medicine, and as you can see, the background is different now. So now we're in Miami, Florida, doing cardiology fellowship. Just came down here about a week or so ago. So this is just to continue our series where we speak about the main clinical pearls from the questions I am doing as I prepare for the ABIM examination, which is the Internal Medicine Certification Examination. And let's just get to the action. Let's try to get this one sort of quick because I have several things to do. So first question is a patient that was waiting for a surgery. So elective surgery tells you that they are on several supplements. And the question is, which of the supplements increases risk of bleeding? Which of course is one of those things that you always want to pay attention. So not because it's just natural, it's not going to be problematic. Risk of bleeding is a serious thing. So that's one of the main things to be aware of. And of course, even more in fields like cardiology or internal medicine. So it's going to be, of these options, it's ginkgo biloba, but there's other supplements such as saw palmetto and it's saw palmetto, ginkgo biloba, and ginseng that increase risk of bleeding. The other options you see here, ephedra is, I think, where the ephedrine comes from. So that was used in the past to increase, I think, athletic performance. Kava is something that is an anxiolytic and has helped apparently in ADHD, but it can be associated with some pretty bad GI disturbances such as hepatotoxicity. St. John's wort, I think that one, of course, affected the P450 enzyme. Was it an inducer or not? So that's an important point here. I think it was more of a cytochrome P450 inducer. No, not sure, because here, let's just review it here. St. John's wort used for centuries for depression. And let's see. It's just telling you there the interactions. But remember from step one where you had St. John's wort and there was a mnemonic, it said chronic something fen steals from something. So I think that mnemonic was an inducer because there was another one that was ramps up something. And that was ramps up were the inducers and steals fen. That included, I think, phenytoin. So that one was a inhibitor. If this logic makes sense, let's look it up. St. John's wort mnemonic on P450. Let's see if that works. St. John on a wort. Doesn't say nothing. No, there's a whole lot of mnemonics, but let's see in summary what it does. It's an inducer apparently, so it increases the activity of cytochrome P450 and reduces plasma concentrations of certain drugs. Okay, so it's not only logical, because if you think that St. John's wort will just decrease the concentration of things, you're not necessarily correct, because yes, it's cytochrome P450 inducer, but how is it generating potentially serotonin syndrome if you're giving it with other antidepressants, right? So it's actually sort of potentiating there the thing. If you're giving it with anticoagulants, it will decrease INR. And of course, I'm sorry for all the background noise, but that's what I offer you right now. And my wife loves to make noise in the kitchen. Then we have other options here, such as licorice. Licorice, it might be associated with hypertension and hypokalemia. Echinacea might be associated with allergic reactions and dyspepsia. Ephedra, we already talked about it. That's it. Let's go on to the next one, right? Better. Okay, this next one is basically how does pericarditis affect the EKG a long time. So initially what you see is ST segment elevations everywhere, right? ST segment elevation in all leads, that's pericarditis. If you just see ST segment elevation in the anterolateral wall and that's it, it probably is a STEMI or something else, or it's maybe a dilation and aneurysm of the apex or something weird, because whenever you have the ST elevation everywhere, that's pericarditis. Of course, in AVR, it's going to be inverted, so you're going to have an elevation of the PR interval and the depression of what would be the ST. So that's what happens acutely, but over time, what happens is that the T wave will be basically flat, it'll come back to baseline, and after some more days, it will be inverted, and that's the answer. So diffuse T wave inversion, so 1 week later after the pericarditis, and that's it, and this is just the representation of what we just spoke about. So we already spoke about the acute phase. We spoke about a little bit later that it basically normalizes, then it's inverted, and then it comes back to normal. And let's go on to the next question. This next question right over here is an 18-year-old woman with 6 months of painful menstrual periods. So how was I able to rule out most things and make sure that this patient just needs a combination oral contraceptives? Because this seemed like primary dysmenorrhea. So in a question stem where they're basically telling you that this patient is having the pain only during menstruation and no other time, and they're sort of inferring that everything is good OBGYN-wise. So you have pelvic examination and remainder of the physical examination within normal limits. Pregnancy test is negative. So everything is normal and she's not actually using any special medication. So the right answer here would be either NSAIDs or combined oral contraceptives, unless the patient has a contraindication for estrogen and progesterone, they might, if they have a contraindication such as pulmonary embolism, or they are a smoker older than 35 years of age, then you might want to just do the progesterone, and not the estrogen component. And there's a nice algorithm here. So for primary dysmenorrhea, we already spoke about the two different options we could give. Then you give that for 3 months. If that resolves the symptoms, just continue that management and that's it. But of course, if it does not resolve the symptoms, now you're gonna combine the NSAIDs with the oral contraceptives and try it out for another 3 months. If it works, good, and if it does not work, then go on to the next diagnostic approach, which will be pelvic ultrasound to rule out fibroids or uterine abnormalities. So of course, if you find something, you treat it. If the ultrasound is also negative, you do a trial of GnRH analog or diagnostic laparoscopy for endometriosis. Remember that endometriosis might be just a little small foci in the cul-de-sac in there that you might only be able to see with the laparoscopy. So first, make sure you rule out all the other things. Of course, you don't want to do a laparoscopy out like from the start, because it would be way too invasive and unnecessary. So those are the main points here. We already talked about the others. Now going on to the next question. This question is a 28-year-old female who is on her first pregnancy, is having some signs and symptoms of GERD. So this is basically telling you, this that I underlined is just telling you this patient has GERD, and over-the-counter antacids haven't done much. So what's your next step? Of course, your next step is acid-reducing therapy, and that's the right answer. One thing is acid neutralizing therapy. That's what you can do with over-the-counter. You can do calcium carbonate. You can do sucralfate. All those approaches are acid neutralizing. But acid reducing therapy is basically reducing the secretion of acid. And the way you'll do that is going to be with the H2 receptor inhibitors, such as the ones that finish in tidine, famotidine, ranitidine, all those, cimetidine. Then you'll do if that doesn't work, you do the most effective one that acts upon all the different receptors that would funnel into one only secretion of or activation of the hydrogen potassium ATPase, I believe, on the luminal wall, parietal cells wall. That's too much information, right? That's unnecessary. The point of it being that you do a PPI, and the PPI can work. So this is another algorithm that is showing you good ways to manage GERD in pregnancy. So here you have dietary and lifestyle changes, then antacids, then sucralfate, then the H2 blockers, then proton pump inhibitors. And if none of that works, you end up doing the esophagogastroduodenoscopy. And that's about it. And let's move on to the next question. Okay. This next question is interesting because, yes, these questions are always there in step 1, 2, and 3. You're always going to get a question of this patient that is all of a sudden febrile and all of a sudden this patient was not febrile. Something happened, something was done, and the patient now is febrile and has either some muscle problem. They're either rigid or they are hypertonic and hyperreflexic, or they are, that's basically it, or they're also having some altermentation associated to that. So there you have the differential of serotonin syndrome and neuroleptic malignant syndrome and malignant hyperthermia, right? So I think I got all those names right. Let me know if I missed one in the comment section below. So remember that each of these happens with a different nauseous stimulus. So in this specific case, they were telling us that this patient was on an atypical antipsychotic. So the atypical antipsychotics have lower risk for producing the neuroleptic malignant syndrome compared to the typical antipsychotics, meaning the other antipsychotics, which basically what they inhibit, Haldol, fluphenazine, that was more serotonin, I believe, instead of dopamine. So let's just confirm here. Let's see if they mention it. I'm not sure if they're mentioning it, but just tell me in the comment section below if we were right with that. How was I able to determine that this was neuroleptic malignant syndrome and not serotonin syndrome? Because although this patient was also on a SSRI, I think, let's see, this patient was also on an SSRI, selective serotonin reuptake inhibitor. The patient was not having hyperreflexia, and whenever you have serotonin syndrome, one main differentiating factor, at least on these tests, is that neuroleptic malignant syndrome or the other malignant hyperthermia, rigid, just hard, doesn't move, while there's a lot of hyperreflexia on serotonin syndrome, so they weren't mentioning that. So it was probably more of NMS. And first step to do is, of course, discontinue the offending agent, which was the fluphenazine. And if that does not work, then you do the dantrolene or bromocriptine, right? So dantrolene or bromocriptine will work for, I believe, those two, for neuroleptic malignant syndrome and for malignant hyperthermia, while serotonin syndrome, what you would want is cyproheptadine. And let's go on to the next question, okay? So this next question is another important one for you to be able to differentiate vasculitis. So in this specific question, or the main point of this question is we want to test your ability to differentiate GPA, which is granulomatosis polyangiitis with the other one, which is Churg-Strauss, which now is called eosinophilic granulomatosis with polyangiitis, I believe, EGPA. So yeah, GPA was known as Wegener's in the past. EGPA is now known as Churg-Strauss. But in summary, both of these can be a little bit tricky. The way you differentiate them is that both can affect this area, the upper respiratory tract, but the GPA or Wegener's will give you more sinusitis, while Churg-Strauss will give you more allergic rhinitis. What else? Bleeding is more associated, bleeding from the nasal cavity is more associated with Wegener's or GPA, right? Then you have lungs can be affected in both of them. You will have cavitary lesions in GPA, and you'll have like transient infiltrates in EGPA. The kidneys are usually not affected in EGPA, but are affected in GPA. So kidneys, here you see that, yeah, in this patient, he has acute kidney injury, so that's more of GPA. And to be honest, on this x-ray, I'm not sure exactly what they were trying to reveal, but the other thing they were giving us is that they were asking us is what marker would be elevated or more likely to establish a diagnosis. So C-ANCA is the one associated with GPA. C-ANCA is also known as proteinase 3. So remember, C is the third letter of the alphabet, so that's going to be proteinase 3. It's the same thing, another name for it only. And that's associated with Wegener's in about 90% of cases. So here you can see 90% of cases in C-ANCA, or C-ANCA here, proteinase 3, C-ANCA. While the P-ANCA is associated more with microscopic polyangiitis, and it's basically half and half with Churg-Strauss. So that's basically it with those. Let's see what else we have. Let's see. So granulomatosis with polyangiitis presents classically with sinus disease, pulmonary disease, renal disease, and systemic symptoms. ANCA-C and proteinase 3 antibodies are most commonly associated with GPA, and the diagnosis is confirmed by tissue biopsy showing vasculitis. Now moving on to the other one. This other question is of a 24-year-old man who was basically healthy, who all of a sudden required some rescue inhalers, and he used that and sort of did well in the hospital, and then had to use it again. And I think Kari doesn't hear the noise she's actually doing, but it's that or not preparing the food. So let's ask her. Kari! No, she can't hear us. Could you lower that? Okay. So yeah, we're not gonna compromise reducing the sound and affecting the kitchen. So let's just continue with this. We'll be done soon. But remember that in any question here with the inhalers, the first thing you want to do is to make sure that the person is using the inhaler adequately. So whenever you have one of these questions, unless the question stem or the vignette tells you the patient has demonstrated adequate use of the inhaler, well, if it says that, you cannot answer that again as an option, right? That's the right answer. So if they don't say it, you'll always have to assess their technique and provide education. Now let's go with the other option. This guy is a 72-year-old man. He fell on his shoulder. It was a mild fall, braced with his outstretched arm, and hit it and fell over his lateral shoulder. His shoulder, well, when he lays on that side, it keeps him awake at night. He has problems with abduction, is unable to maintain 90 degrees, just like I'm doing right here, and has weakness with external rotation, doing this. So I had these symptoms at some point in time. And yes, it was a rotator cuff injury. So it was rotator cuff tendinitis. It was maybe a partial tear, never a complete tear, because of course that would require surgery. So that's rotator cuff tear. How can we differentiate that from impingement? We'll see in a moment. So in impingement, let's see, there is some subacromial tenderness. So the acromial, here, remember you have the acromion here and the clavicle here. This is the AC joint, acromioclavicular. So subacromial tenderness would be right over here if there's impingement or tendinopathy. If there's cuff tear, you'll have weakness. So pain with the impingement or tendinopathy, weakness with the tear. And adhesive capsulitis or frozen shoulder is what it explains. You won't be able to even move that arm very well passively because it's frozen. Biceps tendinopathy or rupture, the main thing that biceps does is, well, it's supination. So, not pronation, supination. So I would expect a lot of pain with supination, but it doesn't say that here. So anterior shoulder pain, pain with lifting, carrying, or overhead reaching, and weakness is less common. The glenohumeral osteoarthritis. So it's uncommon and usually caused by trauma, decreased active and passive abduction, and external rotation. And that's about it for that one. Let's see what else we missed. Okay, that's it. Now, this other question is, yeah, it's interesting because I wasn't sure of the diagnosis. So this clinical vignette was asking me about toxic shock syndrome and how were we supposed to think about it? Because this patient had a fracture or was, let's see, um, the patient, he had a nasal fracture following a bar fight 3 days ago, which was reduced and stabilized with nasal packing at another hospital. So it was the nasal packing. So they packed the nose and probably they left the packing there for 3 days. Maybe the patient had to go to the ED to remove it and he didn't go, forgot, left it there a couple more days. Well, of course, that's what happens. Toxic shock syndrome, which is very risky. Same thing would happen in the past with the Tampax, that if they were stayed in there for over, I think, 12, 24 hours. And yeah, so this patient developed toxic shock syndrome. What I actually thought happened with this patient, since they were saying the patient was having altermentation and all that, I was thinking that the patient actually had the fracture, nose fracture, had an infection that ascended into the brain and had either encephalitis or meningitis. But it was actually toxic shock syndrome causing all the altermentation, hypotension, etc. So how do you treat toxic shock syndrome? With vancomycin, cefepime, and clindamycin. Um, Vancomycin definitely will attack it. Clindamycin will attack the preformed antibodies, I believe. Like, what is it? Uh, we'll see it right here. And I'm not sure what cefepime will do. I'm guessing you just have to have some gram-negative coverage just in case, because this patient is in shock and you just can't risk it because you're not 100% sure it's toxic shock syndrome until you get some cultures back. And let's see what else we have. It says staphylococcal toxic shock syndrome should be considered in patients with abrupt onset fever and hypotension and diffuse erythroderma. Most cases occur in the setting of tampon use, nasal packing, surgical or postpartum wound infection. Treatment involves supportive care, removal of foreign body, or surgery, and broad spectrum antibiotics, such as the ones we mentioned. So, okay. Um, let's see. Empiric treatment typically includes vancomycin, cefepime, and clindamycin. Clindamycin is highly effective at inhibiting toxin. So that's what I wanted to say. The toxin production due to interference with the bacterial ribosome. And okay, that's it. Going on to the next question. This other question wants to test your ability on what to do if a patient has an elevated INR. So a patient with a mechanical aortic valve was placed on warfarin. We have a lot of those patients on warfarin, and he comes to you for any other reason. You just check an INR. This patient is admitted for maybe pneumonia. You check an INR, and INR is 12. So what do you do? So you just have to know if, number one, is the patient bleeding or not. Okay, so if the patient is bleeding minimally, you take it as if they're sort of not bleeding. If they're bleeding moderate to a lot, then you just act and you want to give prothrombin complex. Well, of course, you want to immediately stop the warfarin. You want to give IV prothrombin complex plus minus IV vitamin K. Remember, vitamin K's onset of action will not be like immediately. So if you have more time, you would do vitamin K. So basically, if your patient is bleeding significantly, moderate to significant, you act now. If your patient is not bleeding or bleeding minimally, you see the INR number. If the INR number is less than 4.5, you might skip one dose, 1 to 2 doses, I believe. Yeah, 1 to 2 doses. If your INR is between 4.5 and 10, you hold warfarin and just hold it and resume when the INR is therapeutic. You can give some oral vitamin K if there is increased risk of bleeding. If the INR is above 10, you hold the warfarin and give a high dose of vitamin K, still oral vitamin K, and that's about it. So we got it. Moving on to the next question. So this other question basically tests your ability to determine what to do with a patient that has recurrent UTIs. So what do we mean by recurrent? So recurrent UTI is defined as 2 or more UTIs in the past 6 months, or 3 or more UTIs in the past year. That's going to be recurrent. If you have a patient with recurrent UTIs, you can give prophylaxis. So if the UTIs just occur randomly, you can do antibiotic prophylaxis every single day. Antibiotics, the options are going to be fluoroquinolones, trimethoprim sulfa, and nitrofurantoin. I would probably leave the fluoroquinolones last because you're risking more complications and C. diff, etc. And maybe resistance and all that. If your patient just has the UTIs after sexual intercourse, such as this patient, and you basically give this patient post sexual intercourse the antibiotic. You tell them to take it post sexual intercourse, and that's why the answer was this was 1. Okay, post-coital antibiotic prophylaxis. Now we're going on to the next question here. This next question is a 63-year-old man who has a prosthesis of one of the 2 knees, the right knee, and the patient has been having, well, this prosthesis was done 3 months ago. Right total knee arthroplasty 3 months ago, and now he's having pain in that knee. The knee is swollen, The surgical scar is intact without surrounding erythema. And what do? And all the labs are pending. Well, you should aspirate the prosthetic joint because there could be some arthritis there associated to the prosthetic material. The only way you will know that is with the aspiration. And that was that. Okay. Now, moving on to the next question here. This was a tough one because it was a 63-year-old man with gait instability. He had several symptoms. So he was having double vision. He was having some difficulty walking. He was having horizontal nystagmus and chest X-ray showing right upper lobe lung mass. MRI of the brain with and without contrast was normal. So I thought this was maybe spinal cord metastasis, which made sense. There is a mass there, and the spinal cord. How could the spinal cord generate this patient to have nystagmus? I'm not sure, right? Because nystagmus you would see at a higher level. So up to where does the spinal cord go? Because I think the spinal cord does not include the midbrain. And in the midbrain, maybe you could explain some double vision there. So the real answer here was cerebellar degeneration. And when I did this question, I thought to myself, maybe this patient is having a paraneoplastic syndrome. And that was what the patient was having. But then I let that go and I went with metastasis. This patient was having paraneoplastic cerebellar degeneration. And that's why all those symptoms. There are some antibodies that might be associated to that, such as anti-YO, anti-HU, and anti-RI. So they can be helpful confirming the diagnosis, but negative does not exclude the diagnosis. And that was that with that question. Now, second to last question, you just get this image. Just with the image, you don't have to go read the rest of the thing. It looks like serpiginous. It looks like there's like a worm moving there. Well, yeah, that's the worm. It's called larva migrans cutanea, or larva migrans in the skin. And most of these patients just have these symptoms, and on the feet or wherever they're exposed to maybe contaminated soil or water. Usually it's found, I think, in feces of some animals, such as, I think, cats, dogs, and all that. But usually it does not go to the lungs. If the patient is immunocompromised, yes, this can migrate to the lungs and can be very problematic. But if not, it won't. So that's what the patient had. And the nice little hookworm is called Ancylostoma brasiliense. And that's about it. Treatment is going to be ivermectin, the preferred one, and secondarily maybe albendazole. And that's it for that one. Now, let's go on with this patient here, 48-year-old man in the surgical intensive care unit for tachycardia and hypotension. And this patient, let's see, has history of hyperlipidemia, no heart disease. Current medications include piperacillin, tazobactam, famotidine, a couple more. The patient is intubated on ventilator, is febrile, is hypotensive, tachycardic, saturating fine on 40% FiO2. And the question is basically telling us, what's the question? What do we do next? So, and the patient has, of course, atrial fibrillation with rapid ventricular response. So they're asking us which of the following is the most appropriate next step in management. So I thought, this looks like AFib with RVR, rapid ventricular rate. And this patient is hypotensive, unstable. Let's cardiovert the patient. Well, I was incorrect, and I was correct with what I thought initially, which was that, yes, you treat the underlying cause because this atrial fibrillation, de novo atrial fibrillation, was secondary to the undergoing condition, which was basically septic shock. So how do you start treating this patient that is very septic? With intravenous normal saline, and afterwards you do norepinephrine. And that's it for this one, and we'll go to, that's it for this video. See you in the next one. Peace.